Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. As a reminder, this content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. Today, we continue our benzodiazepine tapering content, how to plan and execute a taper based on the actual benzo the patient is taking. The first step in any taper is identifying the specific benzo and its half-life. Short-acting benzos cause faster interdose withdrawal and higher symptom burden. Long-acting agents smooth the process but delay symptoms. You cannot taper these drugs the same way and expect consistent outcomes. Let's start with alprazolam. Alprazolam is the highest risk benzodiazepine to taper. Short half-life, high potency, rapid rebound. Before any taper begins, alprazolam must be converted from PRN use to a fixed daily schedule. Doses must be evenly divided, usually 2 to 3 times per day. Once stabilized, reduction should not exceed 10% of the total daily dose every 2 to 4 weeks. Symptoms often appear early, even with small reductions. If alprazolam is tapered too quickly, patients experience withdrawal, not relapse. Many patients cannot complete a direct alprazolam taper, and cross-tapering to a long-acting agent may be necessary, but only after stabilization and only when clinically appropriate. Next, lorazepam. Lorazepam presents a different problem. It has an intermediate half-life and no active metabolites, which means withdrawal symptoms can emerge abruptly. Lorazepam should always be stabilized to scheduled dosing before tapering. Dose reductions of 10 to 20% every 2 to 4 weeks are typical. The most difficult phase often occurs below 1 milligram daily, where rebound anxiety and insomnia become prominent. If symptoms escalate, the correct response is to hold the dose, not increase it, and not oscillate between doses. Let's move to clonazepam. Clonazepam is frequently underestimated. Its longer half-life gives a false sense of safety, but its potency creates delayed withdrawal. Total daily dose must be confirmed carefully as patients often underreport use. Reduction should be small, typically 1/8 to 1/4 milligram per step, with holds of at least 3 to 4 weeks. Once below 0.5 milligram daily, taper speed should slow further. Early success with clonazepam often leads to over-aggressive reductions, followed by delayed destabilization. Now, diazepam. Diazepam is generally the easiest benzo to taper when used correctly. Its long half-life and active metabolites provide automatic smoothing. Dosing should be consolidated to once or twice daily. Reductions of 1 to 2 milligrams every 2 to 4 weeks are usually tolerated. Below 5 milligrams daily, reduction should slow to 0.5 milligram to 1 milligram steps. Withdrawal symptoms may appear late due to metabolite accumulation, and delayed symptoms should not be mistaken for relapse. Chlordiazepoxide behaves similarly to diazepam and is typically tapered using the same principles. Larger reductions are tolerated early, with slower reductions near the end. In older adults, sedation, falls, and cognitive effects must be monitored closely throughout the taper. Once the benzo and strategy are selected, taper speed must be set realistically. Long-term benzo use requires months, not weeks. Older adults and medically fragile patients require slower tapers than expected. The final 25% of the dose is consistently the most difficult and should be approached with caution. Rushing the end of a taper is the most common reason for failure. During the taper, dose reductions should be planned in advance rather than made reactively. Dose holds are appropriate when significant autonomic symptoms, severe insomnia, perceptual disturbances, or cognitive impairment occur. Mild anxiety and expected rebound symptoms do not require dose increases. Pausing preserves progress. Dose escalation often reverses it. Throughout the process, clinician must distinguish withdrawal from relapse. Withdrawal symptoms are temporarily linked to dose reductions. They often include physical features and improve with holding the dose. Relapse, on the other hand, is persistent. They are not dose dependent and they resemble the original disorder. Mislabeling withdrawal as relapse leads to unnecessary reinstatement and reinforces physiologic dependence. Before initiating a taper, the indication must be clear, the dose must be stable, and the patient must understand the timeline and expected symptoms. During the taper, reduction should be consistent, PRN dosing should be eliminated, and symptom monitoring should be objective. Near completion, final reduction should slow, lingering symptoms should be normalized, and follow-up should extend beyond dose 0. Benzodiazepine tapering is not about willpower or motivation. It is about respecting pharmacology, pacing reductions appropriately, and not mistaking neuroadaptation for psychiatric failure. When done correctly, tapering stabilizes patients. When done poorly, it creates unnecessary suffering and erodes trust. That is the difference between deprescribing and withdrawal. Okay, that's a wrap for today. If you found this episode useful, share it with colleagues across disciplines. Thanks for listening. Until next time.